Okay, perfect. Well, excellent. Well, welcome. This is session 4 of kind of our network start. Next week will be a session on IPC. I'd be really grateful if you can reach out to your IPC colleagues. I think we're going to have a little bit of focus on respiratory tract infections, viral respiratory tract infections, some of the IPC implications of that, a bit about flu maybe, and a bit about flu testing and treatment and trying to reduce the spread of that, but something that's relevant to colleagues across the whole of Wessex. But this session is quite complicated, actually, is the honest truth. I think diagnostics is hard because of the vast array of diagnostics we now have, and because of the obsession people have with diagnostics sometimes, and yet a lack of sort of understanding about how to interpret them. And that's because diagnostics are most definitely not black or white. So I think what we'll do over the next sort of 45 minutes to an hour is talk a little bit about the rationale for diagnostic tests in managing the child presenting with fever. And clearly, as I think I said in the first session, the majority of those children presenting with fever do have an infection, although a small proportion do have non-infectious etiologies for fever. But just in order to use diagnostics sensibly, you, as with everything, need to be logical, and you need to have a clear logic stream for the rationale for why you're performing that diagnostic test. But you also need to have some understanding of the counterfactual data, which, if this was antibiotics, and I think lots of the principles pertaining to antimicrobial prescribing actually relates to diagnostics as well. And we do need to be very cognizant of what the potential harms are of diagnostics and what the limitations are. And without that, those two things, I don't think you should be requesting any investigations. And so these are just fundamental principles. So we'll talk through them. And then we'll talk a little bit about scenarios when you might not need to do a diagnostic test because you can get the same information from in another way, and that might be scoring systems. We'll talk a little bit about scoring systems. We'll then maybe talk a little bit about, we will talk about diagnostic tests and some of the pitfalls, but we'll probably do that as much through the interactive cases at the end. But I want to talk a bit about the different types of diagnostics, infection diagnostics, and they broadly fall into the categories of pathogen-based tests, where you're getting information about the bug, which may be a bacteria, a virus, a fungi, or a parasite, or you get some indication about the host response. So those are often biomarkers, and the most commonly used ones that we know are things like CRPs and neutrophil counts and lymphocyte counts and things like that. And then a bit more about the limitations of the tests, and then probably a big part, and a lot of diagnostics has moved away from conventional diagnostics to these PCRs, and we call those kind of rapid diagnostics, and they can be either point of care, so at the point of where the patient is being managed, or near patient diagnostics, where they're kind of in the lab, but they're turned around pretty quickly. So you're able to use that sort of information to make real-time decisions at the point you're making the initial decisions about antimicrobials and management of the child. And we must talk a bit about rapid diagnostics because they are massive, both in terms of usage and in terms of cost. And as I said, then some interactive cases too. And they're not hugely interactive, but Nick can see if hands are going up. And actually at any point, if people want to put hands up, please do so, because some of this stuff might be a little bit confusing. So I think, if you remember one thing probably from this talk, I probably just remember this one image, which is the jigsaw. And diagnostic tests pertaining to infection, I think the thing I'd like to get across is they just form a part of the process for deciding whether a child, in this case, has got a specific infection. So although there are some, we'll talk a bit more about conventional tests. So those are the things like our cultures, blood cultures, throat swabs, whatever, or serology. And serology is the body's response in terms of the antibodies it produces following an infection. And those are sometimes more useful with bacteria, with viral infections, because sometimes those bacteria are a little bit tricky to identify, but they're kind of much more accessible often than some of our PCR tests. But the other group is these rapid tests, which may either be PCRs, or they may actually be antigen tests as well. And we all know from COVID that that was a form of rapid test, not necessarily as accurate as PCRs, but often considerably cheaper and more accessible and more mobile. You can take a little thing that you take home and you can test yourself at home. You can't really do that with a PCR machine. But the big but is that that's still a very small part of this picture. And actually, you have no idea what this picture is going to be if you only have those two pieces on the bottom right. So, you need the history. And I put this as like my biggest piece. About half the picture can be probably seen if elicited by a good historian. And a huge amount of weight needs to be put onto the history. And unfortunately, I think this is a skill that we're losing. And I think for infection diagnostics or infection decision making, your history is absolutely fundamental. Obviously, examination can yield some useful information. I think the information from examination is probably relatively limited because there are very few pathognomonic bits. I mean, okay, you can look at a throat and see it covered in pus. That's probably pretty useful. But a rash could be anything. A cough could be anything. Even crackles could be anything, and they're more often likely to be viral than bacterial. So examination may yield some. I think observations are useful. And I think they're useful because physiology and the impact of serious infections and sepsis on physiology in terms of capillary leak and then tachycardia, tachypnea, eventually blood pressure, all of that impact on observations. And I think they have a big impact on how you manage your child, especially in terms of timeliness of how you do things. And the other big thing is biomarkers, as I said. So those are slightly different to conventional microbiology tests. These are more host response things like CRPs, sometimes the liver function, maybe the full blood count. And actually only with all of that can you see that that was an E. coli. If you only had the bottom two right-hand pieces, you clearly have absolutely no idea what that picture was. Or if you just had like three of those, you'd be pretty much guessing. So all of this is required to really manage children with infection appropriately. And so then I said, you need a rationale for, what we have to be able to justify every test we do. And the classic ones are like doing a calcium. People tick a box, they tick like bone profile. Suddenly you get a low calcium and you're absolutely pickled if you have no idea why you requested it in the first place. And all that means you do is then you repeat it, and you might do a 125 hydroxycalciferol, you might do other endocrine tests, but it's a complete mess. And so before you ever make a decision about doing a diagnostic test, you do have to meet some criteria. And either you've got diagnostic uncertainty where making the diagnosis will impact on your management. So, a child who's just got a bit of a viral rash but is otherwise well and has got a runny nose, it's of absolutely no, it makes absolutely no difference whether you do test on that child or not. I mean, there might be some extenuating circumstances if the child's immunocompromised, if there's potentially a treatment, if there are very high risk patients in close contact with that child where knowing if it was a specific virus might have an impact. But in general, only if there is so if you can get relatively high diagnostic certainty clinically, you don't need a diagnostic test to tell you or to confirm what you already know. Impacting on management is clearly fundamental. If the result of your diagnostic test is not going to impact on management, it's very hard to justify that test. So that might be pertaining to drug resistance. You might know that someone's got Staph aureus or something, classically it looks like it on the skin. But if you've got significant rates of MRSA or risk of MRSA, you may be keen then to do your swab to get the culture to make sure that you're not dealing with MRSA as opposed to MSSA. As I said, it could be related to close contact. So, flu is sometimes an example of times that we test. We're keen on children being admitted to hospital with respiratory tract infections to test for flu and often RSV, but flu is related to close contacts who may then need prophylaxis if they're fall into a high risk category. And I put into brackets reassuring the family because I really think that's a very poor indication for doing tests, and sometimes we've got to be honest that we're just trying to reassure ourselves, and that's just insecurity on our parts. But I don't think that generally is it should be an indication for requesting tests, is just to reassure the family of something that we know is the diagnosis on the basis of our history, examination, investigations, and maybe more basic tests like inflammatory markers or full blood count. Now, if people put their hands up if they know what this is? And Nick, just tell me how many people have put their hands up.
Looks like it might be one person.
Okay, good. I'm not going to ask you, Joanne, what this is, but this is a Fagan's normograph, and I think it's very hard to it's hard to be able to interpret tests if one doesn't have this concept of a Fagan's normograph. You don't need to know the exact numbers. You don't need to know exactly how those numbers link together, but you need to understand the principles of what this is telling us. And what this is telling us is a number of things. One is that before you do a test, in your head, you have a pre-test probability of what the likelihood of that diagnosis is. So let's take a child with a red throat, covered in pus, who's got no runny nose, who's got a relatively acute onset of symptoms, and maybe has a sandpaper rash as well. Well, your pre-test probability is close to like 90% that that's group A strep. So just keep that bit in mind. What's if you've got a child who's just got a respiratory tract infection, maybe got a coryzal symptoms, bit of a rash. It could be a number of different things. Then you've got your test, and each of our tests, everyone knows the principles of sensitivity. So the sensitivity is sort of aligned with the false negative rate, and the specificity is aligned with the false positive rate. And as you no test is a binary yes or no. It's on an analog scale, but someone has to draw a line somewhere in that scale to decide what is positive and what is negative. And depending on where you draw that line, you end up with a sensitivity that's hopefully relatively high and a specificity that's relatively high. But invariably, we end up with one or the other relatively high and the other one relatively moderate. But based on those two numbers, you can calculate this and call a likelihood ratio. The likelihood ratio is sensitivity over 1 minus specificity. So that can range anywhere from very low, close to zero, all the way up to essentially infinity. And we'll talk a little bit about those in a moment, actually. And then you've got your post-test probability. And what actually you do is you draw a line between your pre-test probability on this Fagan's normogram through that point, which for that specific test is your likelihood ratio, and you end up with a post-test probability. And then clearly the higher the post-test probability, you also then in your mind need to decide at what post-test probability will you then go, yes, it is that diagnosis, and I'm going to manage the child accordingly. And that post-test probability and what you do with that post-test probability is directly proportional to the implications of that diagnosis. So something like meningococcal disease, even if you only think there's a 5% chance of the child having meningococcal disease, you're highly likely to be giving antimicrobials as opposed to something else. And so, so the person requesting the test needs to firstly estimate the pre-test probability based on the history, examination, investigations, contact history, whatever that is of having the condition. They need to have an idea of what that likelihood ratio of their test is. And so if you think of E. coli in the blood, then if you've got E. coli in the blood, your likelihood ratio is high. It'll be up at about 20 or 30. Once you've got a staph epi in a blood culture, your likelihood ratio for that test is modest. It might be 1 or something, because many of those things are contaminants. So that's how you then you can look this stuff up online for what likelihood ratios are, and then you'll reach a post-test probability. And you in your head before you did the test should have some idea of actually kind of what, based on that test and where it takes me in terms of post-test probability, what will my threshold be there for what changes my management? And without that kind of approach, I think it's very hard to use diagnostics, because otherwise you'll blindly believe your diagnostic test that never has a specificity of 100%. And this is the issue that many people face with diagnostics. There's a cognitive bias there that essentially then means that you blindly do what the diagnostic test does. There's an authority bias or something like that. We're going to come to that on this slide here. So these are some of the limitations of doing diagnostic tests if you don't align with the principles on 2 slides ago. So justifying why you're doing the test, or you have no real idea of how to interpret that test result in terms of pre and post test probability and the accuracy of the test itself. So clearly they might be horrid for the child. And our old NPAs, when we used to have to scrape the top of the nose to get cells to do to do, plate that on cell lines and then use immunofluorescence. That was horrid for children, painful actually. But venesection is painful. Doing repeated blood cultures is painful for children. One of the most horrid things we can do is stick needles in children. We've got this concept of false positives, but this is slightly different to this sort of specificity false positive. You can get true false positives. You can get true false positives, which is a limitation of the test, but you can get positives in children that do reflect the fact that the bug is there, but it just reflects colonization. And we spoke about that a bit last week. But children have far higher rates of colonization, especially in their upper respiratory tract compared to adults. So your rates of colonization with strep pneumo or Haemophilus, non-typable Haemophilus, varicella, even meningococcus are far higher in young children than in adults. So that is a limitation of many of the diagnostics that we've got available, and also recent infection. Without having an ability to quantify some of those PCR results, you can be blindly led down a belief that that's the diagnosis when it reflects something that happened 2 weeks ago, because these tests can pick up results on such minute amounts of non-viable virus. And then you can go down this blind obedience cognitive bias that results in you either missing the true diagnosis. And there are plenty of children, babies with group A strep, who've been discharged home because a respiratory viral PCR has had a result on it that have convinced people to stop antibiotics. Or, as I've said before, it can force inappropriate antimicrobial prescribing, and forcing seems tough, but you see that the whole time with mycoplasma results, as I've shown you on previous things, and we'll probably in our interactive cases kind of give you another example of that. We've also got to recognise that tests are not accurate in terms of their sensitivity, and that's often relatively limited, and to some extent it's directly proportional to the quality of the specimen. And we'll talk a little bit about specimen quality in a moment, but just a negative result, and blood cultures have probably got a sensitivity of about 50%, even when appropriate volumes are taken. So that means in quite often we're maybe 50 to 70%, but it's not 100%. So you just got to be cognizant of that. There's a financial cost, and we'll talk about that in a moment, especially with some of our new rapid syndromic platforms. And I think that it isn't a zero-sum game. And this concept of actually you're not able to do this, whatever you do has got an implication, like the wings of the butterfly. And the implication of doing lots of diagnostic tests is that actually it's got an impact on the lab. And the lab staff will then potentially not be able to offer other tests, or may take longer to do appropriate tests because they're so overwhelmed by the deluge of tests being sent. And respiratory viral testing is a great example of that, when that's being sent willy-nilly, that sometimes some of the more fundamental tests we need to do are being delayed. And I think that also has an impact on staff morale, both for nurses, who sometimes wonder why we're doing half of the tests that are being sent, and if you can't justify it to them, then you shouldn't be doing it. And if you can justify it to them, well, then actually that will ease their morale a bit. And for staff in the lab, probably a similar principle. And then the green agenda, and you may recall that picture I showed of all those syringes from IV antibiotics. Well, you can imagine the pathway for the development of diagnostics. Some of those plastic cartridges we use for COVID and all sorts, massive green waste that ends up in landfills across the world. So if we're not doing diagnostics, but we still need to know if we've got specific bugs, are there any other options? Well, there's sort of after group A strep. People will know about the fever pain score, but the fever pain score, you may not know that it was tested head to head with rapid strep tests, throat tests. And the fever pain score came out as equivalent to, so there was no advantage of combining a strep throat test to fever pain over using fever pain alone in the PRISM study that was published over 10 years ago by Paul Little and others. And, and if you make a diagnosis of group A strep, you clearly then treat it. And this scoring system is a highly effective way of identifying, children over the age of 3, I think it is, or 4 and above, who are likely to have group A strep and then would benefit from treatment more from an infection prevention perspective than for themselves, but still who would justify treatment. There aren't that many other specific bugs where we've got great scoring systems that tell us which bug it is. But, for group A strep, which can be quite common, it's quite useful. That said, this whole study, that BMJ study, was done in a research setting. I mean, it was done with GPs who had been trained specifically on fever pain and supported in its implementation. Doesn't mean that when you use it in the real world, it performs as well. And what's actually been done as part of the Group A Strep Surge in 2023 is to introduce rapid strep throat swabs in pharmacies in Wales. And that pilot of the impact of that is currently being the data is being evaluated and hopefully will be published shortly. So there might be some benefit actually of throat swabs. Our other approach to diagnostics is how do you do them? There are loads of diagnostics, and on the next slide or the slide after, I'm going to show you the myriad of extraordinary and extraordinarily costly and time-consuming tests that we can do. But actually, you've got to have a rational approach that common things are common. Do your first-line tests for the common things first. If they're negative, then you may consider moving on to second-line tests if your child isn't better, and only then move on to third-line tests. So all of us can go on to ChatGPT, put in some symptoms, and get a list of 30 different potential pathogens that can cause that pathology. Clearly, that is not a sensible way to do things for many reasons, and probably all the reasons I've said before in terms of, false positives, forcing our hand, probably taking us away from the true diagnosis. So be really sensible with using a hierarchical approach to organising investigations, requesting investigations. And this is a little bit more nuanced, and this is something I kind of thought about just this week, is that sometimes we just don't have very good tests, and fungal infections, invasive fungal infections in children is an area where we have rubbish tests, but clearly huge implications for those immunocompromised children who have fever and may have something on a chest X-ray or CT chest. And so we can do things like Aspergillus PCRs, we can do things like galactomannan, but on their own, neither of them are particularly great. But in some situations where individual tests have moderate specificity, so or sensitivity, their false positive rate actually or negative rate is low, and you've got a condition where your pretest probability is low, such as invasive fungal infection where it's less than 10%, you can end up with a positive test giving you a very low true positive result. We call that a positive predictive value. It's extremely low in that situation. And what you might do in that situation is combine tests. So you might end up doing an Aspergillus PCR, and you may do a galactomannan as well. And together, if they're both positive, your confidence in that being a true diagnosis, your positive predictive value from your combined testing is higher, significantly higher than from any one of those individual tests being positive. Or you could combine it with a host response test. And there's work in the world of sepsis, and we've obviously spoke about sepsis last week and the challenges of diagnosing it, but potentially people are thinking about rapid syndromic platforms, blood PCRs, combined with host response tests like procalcitonins. And so there's maybe something, watch this space, but I don't think that this slide is hugely relevant to the majority of the discussions and the people on this call. This is like pretty nuanced in rare situations, but this is relevant. And this is what our microbiologists like Christina and co, now have to deal with. Days gone by, it used to just be bacterial cultures, and you'd get a bacterial cultures, and then you'd use a series of biochemical tests called APIs to identify the pathogen, along with looking at it and occasionally seeing what culture medium it grew on, etc. We've now expanded the repertoire within essentially all labs to include a MALDI-TOF. A MALDI-TOF is a form of mass spectrometer where you basically pulverize you've got to grow the organism. So on a plate, and you take a little colony, you pick it off that plate and you put it onto a special slide and slide into that machine. And then it zaps it, mass spectrometer, whatever that is, heat or something. And then the tiny little particles that are produced get read up the column of that mass spectrometer. And that pattern is almost like a fingerprint, a unique fingerprint for each different organism. And so quite rapidly now, when something is growing on a culture plate, we can put it on a MALDI-TOF and identify the organism. We still can't necessarily get sensitivities from that. We still need to use conventional ways or genotypic ways for sensitivities, but that's kind of conventional microbiology. But in addition, we have point of care assays. You'll know these from COVID, etc., where we can use ELISA, so antigen antibody technology, where those strips, those plastic things have got some antigen in them. Production of antibody by us or vice versa, then that combination creates a line that's something visible and there's a readout. You know, the next set of things we've been talking about is PCR technology. This exploded after HIV when we needed PCR to diagnose and look at response rates to HIV treatments. We now have it for pretty much all pathogens, whether they're done by your lab as a test that your lab has sort of made itself and then validated. That's kind of quite fiddly. There's a risk of contamination. It can take time to do that validation, or whether you kind of use a commercial platform varies in hospitals. But that's kind of very commonly used now. You can get very rapid results. And the kind of the newest kid on the block, which is still being evaluated, is something called metagenomics, where we look and use this combination of nanopore shotgun sequencing to read little snippets within a sample. So you take out, some bits of the sample, maybe fungi and stuff, and then you can use this technology to try and look for certain reads, and if those reads are present, you can get an idea about what organisms in that sample. But this is stuff that's almost being trialed. It is still being trialed, but you need to have some understanding of the massive repository, and none of us can keep up with this. There is absolutely no way I can keep up with it. I'm not based in a lab. I rely on speaking to my colleagues in my lab or to colleagues across the region, for more specialized tests. But the take-home message here is that you have to have a strong communication pathway with your not just microbiology colleagues, but colleagues in the labs, because the people that run these tests are not your microbiologists. Often they're your biomedical scientists, and they can really help you in terms of giving you clarity about sample types, the swabs required, and all sorts. So we need that active dialogue if we're actually going to optimize how we diagnose children in our labs, and then also give you a flavour of how they're feeling in terms of their morale, and if they're feeling that they're doing loads of tests that are not yielding any useful information that changes patient care. And it might be you're able to explain to them that it is changing patient care, but they're just not able to see that. And that's why I really do feel that although we've badged this as antimicrobial stewardship, there is the antimicrobial stewardship, diagnostic stewardship, infection prevention is kind of all done by the same group of this infection hub that we've been trying to get together from each of our hospitals, and that these tests should be requested by people who have an appreciation of the pros and cons of diagnostic tests, who have a knowledge of how to interpret those tests correctly, and as importantly, have a responsibility in terms of decision making. So it's the person who's making the decision about management who clearly should be deciding whether a test is indicated or not, and then interpreting it, and also has either is impacted on by IPC, which we all are, because an IPC outbreak, a nosocomial outbreak, can then have a significant impact on our cubicles and patients. But there has to be some understanding of IPC, because diagnostics are often very helpful in trying to improve IPC processes and identify lapses in them in a timely fashion. Clearly, diagnostics, we can't just have the infection team requesting diagnostics, but I do think it's a role of the infection team to start teaching all clinicians, frontline clinicians, about how to use diagnostics. And I think that another responsibility is for the GMC, etc., and all of our medical schools to ensure that this kind of training and understanding is embedded within the undergraduate curriculum, because there is absolutely no way that someone who calls themselves a doctor coming out of 5 or 6 years of medicine doesn't understand the principles that I put on these slides so far, and the principles that we've discussed in the first 3 talks about antimicrobial prescribing. But clearly there are situations where we do need to do tests. Actually, if you can make a very good stab at a sensible first line treatment based on your clinical assessment, then actually there isn't much of an added value of doing a diagnostic test. And cellulitis is one of those examples. There are good scoring systems clinically to allow you to decide whether you need IV or oral treatment. But we know in this country it's going to be Staph aureus or Group A strep occasionally. But both of those are managed with essentially a similar antibiotic, Fluclox, Cefalexin, something like that orally. Pneumonia, very similar. Our bugs are going to be a strep pneumo. They're going to be sometimes a non-typable Haemophilus, sometimes a Group A strep, Moraxella. But once again, your treatment is not going to be massively changed depending on whether you make a microbiological diagnosis for either of those conditions. And your clinical acumen is relatively accurate in terms of deciding whether it's cellulitis or not. So those are situations where historically people have been doing diagnostic tests. For cellulitis, waving a swab on the skin is clearly utterly pointless because cellulitis is not just roaming around on the top of the skin, but people would then consider blood cultures and all sorts, which have got an extraordinarily low yield. And I'll talk about that in a moment. But the situations where I think one should be considering doing diagnostics is where it is hard to pick whether this clinical phenotype, this infection, is bacterial or viral in etiology. And neonatal fever is a very good example where you've got significant rates of early onset sepsis. They're still not spectacularly high, but they're higher than in most other age groups within paediatrics. And there you would be keen to try and distinguish the two because of the significant harms of antibiotics and prolonged antibiotics on the microbiome in neonates. So that's a sensible place. And I'd have a lower threshold for sending diagnostics, including cultures. Another one is where your host doesn't quite fit your classic host. So let's take an immunocompromised patient with a rash that might look like cellulitis. Well, I would be keener to think outside of the box of Staph aureus and Group A strep, and that might involve additional investigations. So I think that we've got to take a more permissive and more liberal approach to diagnostics and treatment, as I've said before, for immunocompromised patients. I think ones with comorbidities, I think, would also be more careful, and that's because a child with congenital heart disease who gets a nasty infection is quite likely to deteriorate. So they're quite likely to end up coming in potentially, or if you don't treat a bacterial infection appropriately, that could end up with an admission to PICU. So that implication aspect might end up with a lower threshold for trying to make a microbiological diagnosis. And then obviously children who have an increased risk of resistance, and that might be because they're colonized with resistant organisms. Then in that situation, you may well go for that broader antimicrobial anyway until you've got clarity about the bug and the resistance. Or if they've come from a hospital elsewhere, it could be a London hospital, a Manchester hospital, a New Delhi hospital, a Romanian hospital, any of those places where resistance rates are higher than in Southampton or Basingstoke or the Isle of Wight. But once again, thinking back to if you decide to do tests, these are the kinds of things you just have to have in your mind so that the result you get, you're able to interpret. And firstly, can you get a good quality sample? And the classic one here is a child with chickenpox. You ask someone to do a viral swab and they kind of rub a swab, hopefully the right swab, a viral swab, as opposed to a charcoal bacterial swab over a vesicle. Well, clearly the yield from that is pretty poor. You need to, in fact, open up one of those things and try and get a sample from the base of one of those vesicles. You've got to, as I said, understand the sensitivity and specificity of tests and ideally kind of have an idea of the likelihood ratio and how that moves from pre-test to post-test probability based on that result. Knowing when symptoms began and choosing the appropriate test. So thinking of a PCR test for, say, whooping cough, when actually if the symptoms have gone on for more than a certain amount of time, your yield from that will be limited, whilst yield from serology would be considerably higher. So there's something about when multiple tests exist for the same organism, deciding on which is the appropriate test based on the timing. Prior use of antibiotics and antifungals often has a significant impact on the sensitivity of tests. You're far more likely to have a false negative result. We know that, with if you give a dose of ceftriaxone and do your lumbar puncture 24 hours later, you're never going to isolate pneumo or meningococcal B, meningococcal C, from that CSF. And it's similar with antifungals with children who are on prophylaxis. It can make our tests that we use kind of far less useful. And then transport time and condition. Urine, CSF, they need to get to the lab in a decent time frame. Doing a cell count on CSF, if it's been sitting around for 8 hours somewhere, that has a significant impact on degradation and of those white cells. And when you're then using those white cells to give yourself an idea of whether you're dealing with a meningitis or bacterial meningitis, then that's relevant. So we spoke a little bit about sample quality. We've spoken previously about clean catch urine specimens in young children, which are often a complete waste of time. And, we have a patient in our OPAC clinic today where a sample was taken, clean catch, not sent for culture, had some leukocytes on a dipstick, and the child's got adenovirus, and it's a decision has now been made to continue those antibiotics because the UTI couldn't be ruled out. Well, that's completely, down to that poor quality sample in a child that clearly had adenovirus and not a UTI. So we've got to just be cleverer about children where we really want to avoid unnecessary exposure to antibiotics. Those two swabs, they're both swabs, but clearly if you send that black one on a child that you're trying to do viral PCRs on, you're just going to get no results. And that will then probably end up with antibiotics being continued for longer, as was the case in the child I just mentioned. That child has been on antibiotics for 4 days because no one sent the right viral swab in the first, when the child presented, and only yesterday when it was repeated and we got the result today, have we been able to make the diagnosis. And then we've spoken previously about the, red colonization. Don't swab those red gastostomy areas in a systemically well child because it's purely going to be colonizing bugs. So that's the kind of education where sometimes those people who aren't making decisions about antimicrobials are sending tests in with the best intentions, but potentially with adverse implications on the lab and the patients themselves. So let's briefly, every week I seem to talk about blood cultures, so this will not be an exception. We've spoken last week about timing of reading, and 24 hours for neonates and children is highly effective for community-acquired infections. But this concept of contaminants is really important because contaminants can very much lead people through that authority bias thing where you can be then forced into giving treatments that are not of any benefit to the child. And this concept of a tipping point for blood cultures, I think, is something we're going to start talking about over the next couple of years in children, where clearly you want to do blood cultures if you've got a good chance of yielding a pathogen, because then you know what you're treating, you'll get sensitivities, and if it's in the blood, it's highly relevant. But if you end up doing blood cultures on every child presenting with fever, when you know that the percentage of children who have pathogens is down at about 2%, then what you're going to do is get far higher rates of positive blood cultures with contaminants than with pathogens. And that's what was shown in that Portsmouth study. If you remember the absolute numbers, which you won't remember, but for every 10 blood cultures that were positive, 8 of them or 7 of them were contaminants and 3 of them were pathogens. And so we need to be clever at thinking about which pathologies should we be sending blood cultures for, and not just repeating blood cultures repeatedly daily for the sake of it, because then if you do 7 blood cultures or 5 blood cultures, one of them will definitely be contaminated. So clearly for sepsis or for eclampsia, central line associated bloodstream infection, you need to do a blood culture before starting antibiotics at the right volume, 4 mils in a Bactec bottle. But for certain things like cellulitis and pneumonia, where we know from all of the evidence that the yield from blood cultures is down below 0.1% probably for cellulitis or pneumonia in the child that isn't systemically unwell with sepsis, then your contamination rate is going to massively outnumber your pathogen yield. And then it's not in the best interest of the child or the lab. So something to think about blood cultures. So maybe this is a QI project we'll do as part of this network at some point. And we're doing some work nationally to try and provide a bit of guidance through the Royal College or through somewhere, NHS England. Serology, I'll just talk about in one slide. I said that it can be very helpful actually, and people have heard of Lyme serology, they've heard about EBV serology, and serology is good because it's offered, much more routinely in places than some of our PCR technology. It's much cheaper. And it can give you a bit of an idea about timelines where sometimes PCRs can, but you need to do a little bit more homework with them. So IgM is produced before IgG. If you've got a strongly positive IgM result and a low or negative IgG result, that would suggest an early infection. You'd kind of confirm that by doing a convalescent sample about 2 to 3 weeks later, where at that point your IgM would have dropped and your IgG would have risen as per the graph here. So it's a little bit of a faff, but I think there is a slight risk with serology that people don't quite appreciate who don't request lots of serological tests. And this is that concept of cross-reactivity. So cross-reactivity is when you have a positive IgM result, but not because it's IgM against that pathogen, because it's IgM against something else. It's cross-reactive. And that can give you a false reassurance when the IgG is negative for that pathogen that this is an early infection with X, when in fact it's not at all that is related to that infection. And the way you might identify that is by actually delving into the absolute level of your IgM positivity. And if it's very close to your cutoff of positivity, I'd take that with a pinch of salt and go back to your drawing board and try and work out what the real reason for the fever in that child is. So kind of coming towards the end, rapid diagnostics are very much the present and future for diagnostics. And that's because they're quick. They're often able to yield results for pathogens that don't culture, like viruses, where it's very difficult and costly to culture viruses. But they do need to be accurate. And that's where we just need to be mindful, especially with our antigen-based tests, where the accuracy is sometimes not as high as we'd like. And that can even apply to some of our PCR tests, actually. And the move now is to move away from individual PCR. So instead of just doing a group A strep or a meningococcal PCR, more and more people and labs are moving towards syndromic PCR. So you'll get a gastro PCR, which is for viruses or gastrobacteria, or a meningoencephalitis panel, which will include HSV, VZV, entero, pneumo, group, etc. Pneumonia panels, joint infection panel, respiratory. There's these syndromic panels are often commercial panels, and as I said, in a relatively small size lab, it can be very difficult to optimize these assays and develop them yourselves. If your lab does have in-house PCRs, the cost is vastly different to these commercial panels. In our hospital, we have a bone joint panel that costs about £5, I think, to run per patient. The equivalent commercial panel is probably about £150 to run. So that's a vast difference. So clearly the stewardship of requesting those tests, especially if they're these commercial panels, has to be very tight. Otherwise, you can leach a lot of money very quickly. In addition, PCR technology is very good, but it can also be quite misleading if you are not able to have some understanding of how positive that result is. And with some of our commercial platforms, you can't read the CT value out the back, and so a very high CT value may not represent a true result. And so there's another concern with those. And for some targets, for HSV or for pneumo, you can get false positive or false negative results on that meningoencephalitis panel. For some of these commercial platforms, you've just got to have a good understanding of these. And this is where a conversation with your microbiology colleagues and it is really important. And doing something, that's why bringing micro, paediatrics, pharmacy, we all bring different knowledge sets, and together we're going to be better able to manage our patients. So, lastly, just a few cases that highlight some of the pitfalls and benefits of these tests. I think this was supposed to come in different bits, but this is a 3-year-old boy, presents with a 1-day history of fever, a rash, a cough. He's got an impressive CRP of 110. I think all of us would take that very seriously. He's got a white cell count of 18, and he triggers a sepsis screening tool, as I said, nearly all 3-year-olds with fever presenting to ED do. So he is started empirically on ceftriaxone, and he has an X-ray done that looks kind of relatively non-specific, to be honest. There's some bilateral non-specific changes on there. He has a respiratory panel performed, but this isn't done in a sort of timely way. It's done and it goes off the lab. It's done and actually it's turned around pretty quickly, but then no one really looks at the result particularly quickly. And it turns out it had adenovirus positive. It's also got human metapneumovirus, but adenovirus, both blood cultures negative, the child clinically improves, and antibiotics are stopped at 36 hours, which in theory sounds quite good. But actually, in a situation like this, where people are spending significant amounts of money on these tests, actually that result could have been looked at the point of presentation, potentially in ED, or if they'd been sent to a short stay unit, they could have been looked at in the first 12 hours of that admission. That result could have been seen. The child could have been reviewed in terms of it not being sepsis, and the child could have had their antibiotics either ideally stopped. In the first instance, people might have switched to oral, sent the child home. But I think that if we're using rapid viral diagnostics, they need to then be reviewed, those results, and interpreted appropriately by people with a confidence in those tests in a timely fashion if you're going to get the biggest bang for your buck. And I'll talk about bang for your buck in a few moments. And this could have avoided unnecessary hospital stay, unnecessary antibiotics and all sorts. But it does require an element of confidence. Anne-Marie, I see you've got your hand up.
You probably can guess my point, Sanjay, will be that we wouldn't have a hope in hell of getting that viral throat swab result back within 36 hours, let alone 48 hours. So we don't have the ability to be able to stop as early as that, but maybe that will come in time. I don't know.
Well, but so this is a different issue. I mean, if you're not getting them back that quickly, and I appreciate that, although the magic of PCR testing is all about the speed, we somehow still take a week to get HSV results back from CSF from certain hospitals, and I really struggle with that, and that's I appreciate that means that this kind of case but this is a case where that result was available within 12 hours, and yet people still don't have the confidence. So that the learning from here is not that I'm in a hospital where I don't get results quickly. That is difficult for us to address. I mean, clearly, if you can show your trust that it would have an impact on length of stay, and you get children out more quickly, they may decide to invest in a strategy where those tests are available more quickly. So I think that's how I'd respond to that. The second case is similar. It's a 4-year-old girl with fever, respiratory distress, actually a bit more poorly. Has got SATs of 92%, so needs to come into hospital for oxygen at least, and has got a CRP of 60, who's mildly unwell. Actually, people think this is likely to be a viral respiratory tract infection or an exacerbation, maybe a first presentation of asthma. This child's had eczema before. So actually, impressively, they hold off antibiotics, but they do bring him in for oxygen, which I think is very impressive. But they also send off a respiratory panel because, this child's being admitted and they've got a viral thing. And instead of just testing for flu and flu and RSV, or at least flu maybe, because that would have an impact maybe on infection prevention, they send off one of these commercial panels because that's what they've got available in their hospital. And unsurprisingly, Mycoplasma pneumoniae and rhinovirus comes up. And so at this point, due to that kind of authority bias, people can't not start azithromycin, and this is true of all of our hospitals around the region that are using biofires. It's almost impossible for this child not to be started on azithro at that point, and they are in all hospitals. But this is a real pity, because what's happened here is that by doing an unnecessary test, and there is absolutely no indication for Mycoplasma PCR in a 4-year-old like this, because this phenotype is not consistent with Mycoplasma lower respiratory tract infection, you've ended up exposing them to a very broad spectrum antibiotic that will still be generating resistance 6 to 12 months down the line in this child. And this is just reflective of Mycoplasma carriage, and has resulted in unnecessary treatment and potentially missing the correct diagnosis, actually. And also a future pressure for antibiotics, because these parents are more likely to want antibiotics next time because their child was treated this time. So, I think this is this reflects on, we should be doing tests as we should be asking for the pathogens we want, because when we're not, we end up in a bind like this. And there's lovely data about no benefit at all when a child has azithromycin added empirically for this kind of presentation. And here's, I think, a more difficult case, actually, which is a 9-year-old boy. He presents with fever, headache, lethargy, recently had a bilateral otitis media. He's got a modest CRP, he's got a modest white cell count, and unsurprisingly, he started empirically on ceftriaxone because he does look unwell. And he has a lumbar puncture appropriately, which shows raised white cells, which are mononuclear, 70%. So he's got some polymorphs in there. He's got a raised protein. He's got a glucose that's not bad, and he's got an opening pressure that's relatively normal. And his viral PCRs are done, and they're enterovirus positive. And as a result, this child's antibiotics are stopped. But actually, 24 hours later, he clearly gets worse, and this was all Streptococcus pneumoniae on the culture. We don't do bacterial PCRs on our CSF. We do viral PCRs, and they're invariably just ticked when people see a child for meningitis, and clearly enterovirus can make you poorly. But we've just got to be a little bit mindful that these are rare cases. It's a bit like the positive virus in the baby with Group B strep, where someone gets whatever, an RSV result that's positive. You have no idea of the CT value. There are lots of enteros positive. There's lots of it going around, and just be a little bit mindful with results like that when it doesn't quite fit the clinical picture. And clearly this child had a CT. The ones on the right are the normal mastoids, and the ones on the left are the opacified ones, and you can see how they looked in this child. And once again, this speaks to that pre-test probability. This child, this bilateral otitis media, then headaches, fever, that's not enterovirus. So your pre-test probability for enterovirus was extremely low. So then even with a positive result that might have had a likelihood ratio of 2, your post-test probability was still extremely low. So remember that when you're interpreting results. Well, clinical case 4 is this, and this is probably a case where you do sometimes need to put heads together. This is a child with a right atypical pneumonia, 6 days of fever with a temperature of 40 degrees, productive cough, vomiting, diarrhea, who's been given amoxicillin, somehow for presumed bacterial pharyngitis, but let's say for presumed bacterial lower respiratory tract infection, not getting better, and has that X-ray with a right upper consolidation, has got an adenovirus PCR that's positive, has got a CRP that was very sporting initially that's sort of improved, it's got platelets that are down, has got hepatosplenomegaly, and has got a negative blood culture. And I think many people would still end up treating this for X number of days of antibiotics. Some would often give quite a few days of IV with that CRP. But actually, and this isn't typical for an adenovirus. We had the adenovirus in that case 1, but actually here, I think if you've got the confidence, you would say that this doesn't make sense. That this is a non-comorbid child. They would have improved on amox. You've got an adenovirus, but this is classically, from that CRP is classically adeno. That X-ray could be adeno. The blood culture is negative. So sometimes you kind of need to have people with the confidence to interpret these tests. So if you're going to do them because you're going to act on the results is probably what I'd say. And we've got an adeno case just like this today where this child has had 4 or 5. This is the one where the wrong swab was sent initially, and only 4 days down the line, 6 days of fever, have we now got an adeno result, and we can stop antibiotics. So last couple of slides, it's a horrible looking slide, but what it's actually, all it's saying is that these rapid tests are of very little value unless they're requested and interpreted by people who understand them and have got influence in management decisions. And that's where we as an infection team kind of supports this process, either by doing that or by educating those individuals who are requesting those tests. But at the moment, these tests are being requested and interpreted and used to influence the management of children, of people, by people who have very little knowledge of these tests themselves and their limitations. And it's generating vast costs for very, very little bang for your buck in terms of antimicrobial therapy or optimizing treatment, length of stay, or even mortality and morbidity. So I think if you haven't got the right people looking at these tests, you shouldn't be doing them. because you're actually just getting nothing for vast spends. And this comes down to the spend bit, and these numbers themselves are a bit weird because they're American figures where they spend so much on healthcare. It's mind-blowing. But this is for sepsis and early microbiology, rapid microbiological diagnoses really only have a significant cost benefit if they are embedded within a system with people, infection teams, where people can actually interpret them properly. So I do think that's why we've got to work towards this model. How it works in DGH is much more of an empowerment system where you have a core group of people, the people within this network, who then educate their colleagues, senior and junior colleagues and multidisciplinary colleagues pertaining to infection management, diagnostics and IPC, and then our infection teams support those processes in a more supervisory role and also oversee auditing and benchmarking. And that's probably how we're going to start managing children better with infections. So perform the right test on the right patient at the right time, obviously fundamental even for antimicrobial stewardship. But that is what diagnostic stewardship is. I mean, there is an education piece, very important, which needs to start at medical school, and it's definitely not started there. And the diagnostics pathway, this is an area where we can also do a bit of QI work, and we will over the coming months and years, I'm sure, across Wessex. Thank you. Let me stop sharing if I can, and then let's see if there are any questions. Christine, are you still on? Maybe I might ask you for your thoughts. You actually know lots about diagnostics, and you probably feel much more the frustration about diagnostics than even I do, because it's your colleagues, your wonderful colleagues in the lab, who are bearing the brunt of a deluge of inappropriate tests, often with almost no information on that test, which actually isn't a reflection on poor documentation. It's a reflection on poor cognitive processes in taking the sample, actually, I suspect. I think if people thought about why they were doing it, they'd probably write more sensible information on the request form. But what are your thoughts about any of this?
I mean, I think we get a huge number of inappropriate requests. I wouldn't say paediatrics are particularly bad, though, compared to adult medicine. I would say adult medicine is pretty appalling. Respiratory, you've touched on quite a lot, and I think that is a big part of it. We get a huge amount of, for example, commensal flora in sputum samples, cough swabs, things like that end up being treated when they are just commensals and they really don't need treatment. Similarly, like you say, with respiratory biophiles, they're a hugely expensive test, and they're often done more, I'd say, in adult medicine, but also in peds when they're not needed, and they won't ultimately affect patient management, because the assumption is it's kind of just a kind of a viral infection, and really whatever virus that is has no IPC implications and no treatment implications, so it's a bit of a pointless expensive test to do. I would say a huge problem is requests of urine cultures, which are often done more in adults, I'd say, inappropriately due to dipsticks that are done in 90-year-olds that are completely a waste of time. I think it's probably better in paediatrics, but again, a lot of colonizing flora that's picked up. People don't know how to interpret urine cultures properly, don't know how to look at the microscopy, the epithelial cells and all that. So yeah. I think a huge number of people are treated when they don't need to be for a UTI. And as you all know, we've got a huge problem with resistance and increasing resistance. So yeah, I agree. It's a big problem. I was going to mention one of the cases you said, the strep pneumo one, was really interesting. I mean, most CSF panels will also include bacteria. So I don't know which panel that was that just had viruses.
It's just an in-house. So our in-house panel is we don't do bacterial PCRs on that. We just
okay. So a lot
you're
of
right,
places
the commercial
will,
panels,
for that exact problem. Yeah. I mean, we have had biophiles done before inappropriately that have picked up group B strep that wasn't really there, when clinically it didn't fit, which is a huge problem if it's a baby. And how do you interpret that, and what do you do, and why was the test done in the first place, has to be the first question.
That's the same with pneumo, sometimes with the biophiles, where you get false positives or negative HSVs and all sorts. So, I mean, I think it goes back to that likelihood. And what are your thoughts if we were to do in paediatrics, to kind of 1 or 2 QI projects pertaining to diagnostics, But where would you kind of put a bit of that energy?
Throw my money on. I think the two big areas are respiratory and urine. We don't really get swabs, I'd say, that frequently from kids. Swabs are pretty useless. We get a huge amount from adults, but I wouldn't say that's a big thing with kids. So it's probably more respiratory infections and urine and cultures.
Well, and I think that's very sensible. And I think the third would probably be blood cultures. I think we're going to really try to send less blood cultures. Those pointless ones. I think our rates of contamination are going up.
I think your numbers were pretty accurate. Every day we get contaminants. I wouldn't say we get them more in peds, but neonates are so hard to bleed. I think we do get quite a lot of contaminants in neonates. But every day we get several contaminated blood cultures, and it's quite a bit of work, not only for the lab, but the bottles take up space, and then it takes us quite a lot of time to decide. We have to call the relevant teams, discuss the case. You have to put a comment to say, don't worry about this is likely a contaminant, and it just causes a huge amount of work. And jokes aside, we do see a spike in that often when there's a changeover of doctors as well, people who aren't used to doing blood cultures. And I think we see better culture technique by the nursing staff often than by doctors as well. And yeah, a lot of times blood cultures are done, I'd say probably more in adults, but in kids as well, inappropriately on well people who clearly are not septic and might have, say, a viral urti or something.
And I think this speaks to the whole sepsis agenda as well. Until we can start tackling the sepsis, it's very hard to label someone with sepsis and not do a blood culture on them. But the issue there is not the doing of the blood culture, it's the inappropriate label of sepsis, because you've given yourself no time to actually observe the child. And what I find very interesting about this discussion, Christina, is actually within every hospital in Wessex, these discussions should be happening between paediatricians and their microbiology colleagues. And I suspect they're not, because there's an increasing kind of separation between all of us in our little silos. And so I think that's the real strength of these infection groups, that actually everyone with, paediatrician, a pharmacist, microbiologist, plus or minus a hospital, should get a little bit of time to just brainstorm together, so that actually the stuff that you're saying can then be conveyed by, say, the paediatrician to the rest of the paediatricians. You're not going to go and meet with every paediatrician in Hampshire hospitals, but actually the paediatric infection person can then kind of get that message out if there are things going on in the lab that they need to know about. So communication is crucial.
In places like UHS, where people like you are kind of the bridge in a way between kind of the peds and the labs and microbiology, and DGHs, we are slightly more separate, I would say. We've got amazing pediatricians at Hampshire hospitals and we interact with them a lot, but I wouldn't say we sit and have in-depth discussions about generally diagnostics and AMS and whatever, but they are good at picking up the phone. But for us, I would say interpreting results without any clinical information is so difficult, and we have to do it all day, every day. And the history is really 80% at least, I'd say, of your diagnosis is on the history. And when you get a result that can be interpreted in multiple different ways, without that history, we may be putting out a report that's false in a way, saying, implying this is a significant result or a not significant result, etc. And we're doing that blindly a lot of the time. So the history is really the key, I'd say, above anything else.
Yeah, perfect. Well, that's kind of what we started off with this talk with that jigsaw. And we said, if you remember one thing, remember the jigsaw, and remember that history bit would be about 3/4 of the jigsaw, that one piece, and you'd see the E. coli immediately, and job done. Take proper histories. Okay, well, look, I can't see that many more hands up, and it's gone 4 o'clock. So I'm going to just look at what came up in the chat. We are collecting data. Or is that something different?